I want to talk today about how to manage heavy coronary thrombus. This talk complements my prior talk on STEMI primary PCI, where under the comments section, I discuss 4 major techniques to eliminate heavy thrombus, and I will further elaborate on those and more. I will start with a case to illustrate that. This case was shared with me by my former great fellow Wasawat. This is a patient with inferior STEMI. After wiring and ballooning, they found that the patient has very heavy thrombus burden. And we define heavy thrombus burden as a thrombus length that is more than 2 times the vessel diameter. And in this case, you can see it's far longer than that. This is a thrombus from here all the way to there. So how to deal with this thrombus and how to stent such patient? I will discuss the 4 major techniques of dealing with such thrombus. I will also discuss an additional major idea regarding when and how to stent and 2 other techniques. This will be the outline of this talk. So I will start. The first major technique of dealing with heavy thrombus is to use local 2B3A inhibitors. You inject the bolus or boluses via a distal dual lumen catheter into the clot. If you inject them via the guiding catheter in a patient with a slow flow, they may not reach the target thrombus. And you may ask me, what's the data for local 2B3A inhibitors? This is the major trial, INFUSE AMI, published in JAMA. They took patients with anterior STEMI, proximal to mid-LAD thrombus, and they showed that giving local 2B3A inhibitor bolus via weeping balloon into the clot versus no 2B3A inhibitors reduced MI size by MRI, which translated into better 1-year MACE. There are other studies that address 2B3A inhibitor via the guiding catheter versus IV 2B3A inhibitors, the biggest of which is ADA STEMI, which did not show any benefit of local 2B3A inhibitor via the guiding catheter. The problem, though, is that they use the guiding catheter, not a local distal injection into the clot. Now, the second major technique of dealing with a thrombus is the thrombectomy catheter penumbra. This catheter may be advanced through a 6 French guide, and it's a monorail catheter. This catheter connects to a strong suction system, the penumbra engine. And that's really the main advantage of this thrombectomy catheter versus other catheters. The problem, though, is that the lumen of that catheter is only 3.35 French. So it may not have enough lumen to aspirate a very large thrombus. And I find that that second technique is the least effective technique in patients with a really heavy thrombus. The catheter will get plugged with those large thrombus debris. So the third technique is this, and that's a very important technique, is suctioning via a deeply advanced guideline. So what you do, you advance a guide liner deep in the vessel, close to the thrombus location. That guide liner is wedging the guiding catheter. Then at the back, via the TUI that's connected to the guiding catheter, you connect the penumbra suction system, not the penumbra catheter, the penumbra suction system. So that suction system will eventually be in line with the guiding catheter and with the guide liner all the way into the clot. So it will suck basically the clot through the large lumen of the guide liner, which is larger than the lumen of that flimsy penumbra catheter. So you'll be able to achieve much more suction through this system. And it's better in those cases, once you see that the patient has heavy thrombus, to use a larger system like 7 French, or if you're using groin, 8 French guide with an 8 French guide liner and a heavy suction system. So that was the third technique. Then you have the fourth technique for refractory thrombus that's refractory to the first three, which is using intracoronary thrombolytics, intracoronary TPA 1 to 10 milligram. Now, what's the data for that? There is a trial called TIME trial published in JAMA in 2019, which used slow intracoronary infusion of placebo saline versus 10 milligram versus 20 milligram of TPA over 5 to 10 minutes, and the mean time was 6 minutes, in STEMI patients after balloon dilatation and before stenting. This trial was a negative trial. It showed that RTPA does not improve eventual flow or outcomes. However, it was safe in that trial to use a TPA dose of 10 to 20 milligram intracoronary, and therefore we may consider that dose of intracoronary TPA for a refractory thrombus, although no direct data. And I would suggest using lower doses than this trial, 1 to 5 milligram, administered distally into the thrombus via a distal dual lumen catheter. In that trial, they allowed the use of TPA via the guiding catheter. I would suggest using lower doses into the thrombus over a 5+ minute. You mix that 1 to 5 milligram of TPA in a 10 to 20 millimeter syringe, and you inject it via the dual lumen catheter slowly into the thrombus over 5 to 6 minutes. So those are the 4 major techniques. Now, one important idea is do not stent before alleviating the thrombus burden dramatically and establishing a clean distal runoff. If you stent before achieving those 2 ideas, 1, the stent will thrombose. 2, the stent will shower distal emboli, further impairing the distal flow. So you have to alleviate the thrombus burden and establish clean distal runoff, TIMI 2 or 3, before you stent. Now, if heavy thrombus persists with several maneuvers, but you have TIMI 2, 3 flow, stenting may just worsen the flow and destabilize the patient. Stenting may cause a cheese crater effect on the clot, which will cause distal and branch embolization and aggravate a no reflow phenomena, which will worsen ischemia and hemodynamics and cause more arrhythmia. Even more so in the case of RCA, where you may get profound vagotonia from those distal embolization and shock, or RV shock, or VFib. So if you have heavy clot with TIMI 3 flow, try those techniques to eliminate the clot before you stent. However, if those techniques don't work, if you establish a good runoff, but you have not been able to alleviate the thrombus burden, well, what you may need to do is marinate the patient with 2B3A antagonist infusion for 24 hours and bring back the patient for reassessment, see if that thrombus has cleared, and stenting. But odds are when you have heavy thrombus burden, if you do multiple of those techniques, especially 1, 3, and eventually 4, you'll be able to alleviate the thrombus burden, then stent after alleviating the thrombus burden and establishing a clean runoff. Other techniques, Angiojet. I suggest avoiding Angiojet because there is a major trial, AMI trial, that showed that Angiojet does not improve flow or infarct size in MI and actually worsen MACE outcomes. You may use laser atherectomy for thrombus. Laser atherectomy is known to be an effective technique that I like to use in balloon uncrossable, heavily fibrotic or calcified lesions that are balloon uncrossables, sometimes in conjunction or in preparation for rotablation in very difficult cases. I also use laser atherectomy commonly for underexpanded stents. But laser atherectomy may also be used in thrombus and may be used to vaporize a thrombus. The problem is that it may lead to distal embolization. but that's a technique that could be considered in labs that have laser atherectomy. And those are two papers that support the use of laser atherectomy in thrombus. One published in 2004, the Carmel multicenter trial, which showed that laser significantly reduces the thrombus burden. And it was fairly safe in that study with a 2% risk of distal embolization. This is another case to illustrate those concepts, also shared with me by Dr. Wasawa. So this patient has ectatic RCA with heavy thrombus burden. One, I would suggest here, do not use a GR4 guiding catheter. In general, I don't like GR4 guiding catheter in transradial procedures, but especially when you see heavy thrombus burden, you know you're going to need a lot of support. So I would use AL1. So here what was done, after wiring and ballooning, you can see that there is heavy thrombus burden. What should be done in this case? Penumbra would not do anything, I think, in such heavy thrombus. I would follow the steps I indicated before. I would try local intracoronary 2B3A inhibitors. I would try to advance the guideliner deep and try to aspirate via the guideliner with a TUI connected to the penumbra suction system. Then, if the thrombus persists in such a heavy fashion, I will try to use local TPA up to 5 milligrams, which I think this patient would need. If you choose to stent, you have to absolutely make sure there is excellent flow, a lot better than what you see here, and you need to have significant clearing of the thrombus burden before stenting. Even then, I suspect that there is high chance of distal embolization and shutting the flow once you stent. So you have to be ready. Even in the ideal situation, if you stent such patient with heavy thrombus, you have to be ready that he may decompensate and he may have arrhythmia after you stent. Specifically in this case, IVUS was done, and you may see that he has a heavy thrombus burden, and this is the thrombus you see here, that has heterogeneous, somewhat echolucent structure. You see the thrombus here as we're going. Very nice images of thrombus. All this is intraluminal thrombus. And interestingly, you may see that this patient doesn't have a lot of plaque. He has a lot of thrombus, but not a lot of plaque, intimal plaque. Therefore, he has either plaque erosion on top of mild plaque, or he has what we call thrombosis in situ on top of very ectatic vessel with a mismatch between the proximal vessel and the caliber of the distal runoff. So in this patient, you may not even need to stent. You may just eliminate the thrombus and not stent at all, as there is not heavy underlying plaque or plaque disruption. And here is a summary of this idea. Heavy thrombus without heavy plaque burden. Maybe you have a plaque erosion or in situ thrombosis. Plaque erosion means you have a thrombus on top of a thick cap or thick intima without cap rupture or disruption. And frequently in plaque erosion, the plaque burden is not heavy. And in those cases, there is no absolute need for stenting after clearing the thrombus and establishing residual stenosis less than 50%. And this concept is supported by the erosion 1 and erosion 3 trials. I want to show you one last technique, and I will share with you this case I had during COVID time. This is a 38-year-old man with COVID who presented with inferior STEMI. You can see he has a heavy thrombus burden in the RCA with heavy distal embolization. We tried local intracoronary 2B3A with no success, and we also tried thrombectomy with no success. Since he had some distal flow, we decided to place him on an infusion of 2B3A and repeat the angiogram 24 hours later. The repeat angiogram showed that the thrombus remained the same. So we used here a novel technique for the coronaries. We use the Stryker Trevo NXT Cerebral Stent Retriever system, which is the system used for stroke. It's the stent retriever system. Now, this stent system is different from what we do in the coronaries. This is not a stent that is meant to stay in the artery. This is a stent that is attached to a wire that is meant to be deployed in the vessel, trap the thrombus, and be pulled out. So this is a temporary stent that is meant to trap the thrombus and be pulled out via that wire into the guide, then outside the body. And I'll show you exactly how. So through the guide, we advance a guide wire, then we advance over the guide wire 0.021 inch special over the wire microcatheter, Trevo track catheter. Then we advance it past the thrombus. Then we advance that stent system with its wire through the microcatheter, and we position the collapsed stent across the thrombus. Then we pull back the microcatheter, which unsheathes the stent. So we pull back the catheter, the stent gets unsheathed and gets deployed over the clot. We give it a few minutes, 2 to 5 minutes, to allow it to gradually expand and trap that thrombus. All the while, we could be aspirating through the guiding catheter, aspirating clot through the guiding catheter. Then after the stent is deployed, we pull the system into the guiding catheter, which will collapse it, and we pull it all the way out. In the case of a very distal thrombus, you may not want to pull the trapped thrombus and stent all the way through the vessel into the guide. You may upfront advance a guide liner and position it distally so that you pull that system and collapse it into the guide liner, or you may advance another catheter over the Trevo tract, a larger catheter that comes with a Stryker system, and that will allow you to partially collapse this stent retriever and clot distally in the vessel before you pull it all the way back into the guide. And that's what we did here. You can see here, we deployed the stent retriever into the clot proximally, then we pulled it into the guide. We also deployed a stent retriever distally, smaller one, 3 millimeter versus 6 millimeter proximally. We deployed a 3 millimeter stent retriever distally and pulled it back and collapsed it into a catheter that was positioned distally. Then we pulled it all the way back into the guiding catheter. And this is the final result. We fully eliminated the thrombus here proximally and distally, and you can see the pieces that we retrieved. So again, this is a summary of the 4 major ideas about how to deal with heavy thrombus burden: local 2B3A inhibitors via local catheter, penumbra thrombectomy, catheter with its potent suction system, but that tends to be the less effective system because of the small caliber of the thrombectomy penumbra catheter. The third idea is deep guide liner attached to the suction system of the penumbra. The fourth idea is local thrombolytics, TPA, via a dual lumen catheter, typically 1 to 5 milligrams. Then a major idea is to not stent before alleviating thrombus burden and establishing a clean runoff. If you establish a good runoff, but you have not been able to alleviate the thrombus burden, you may try to marinate the patient with 2B3 antagonists for 24 hours, then bringing him back, rather than stenting in the midst of a heavy thrombus and creating a shower of distal emboli, which will impair flow, cause arrhythmia and hemodynamic compromise, and your stent will thrombose anyway. and two final techniques, which are laser atherectomy and cerebral stent retrieval system that may be tried in the refractory cases.